Good morning, everyone. Good morning, Dr. B. Thank you for being here to learn about the 577. I'm Joan Stauffer. I'm with Iridex. I manage our clinical education programs, and it's my pleasure to introduce Dr. Richard Rosen from the New York Eye to talk about his experiences. Dr. Rosen, please. Thank you.
Okay, well, thank you, and good morning. This morning, I want to share with you just our very early first impressions of using the Iridex 577 yellow laser. We have had it only during brief intervals. It's been very popular. So I really only have a few clinical cases to share with you. But I'd like to just share with you some thoughts about the concept of using this particular laser. As we're all aware, diabetic macular edema is the cause of mild to moderate vision loss in about 40% of patients with diabetes, and so it becomes a formidable problem for management. We're still hanging on to the 1980s, which sort of defined how we treat diabetic macular edema, which at that time was based on contact lens exam, and so in those days thickness was thickness, and there was no really distinction in terms of different types. Nowadays, obviously, we have the benefit of a better technology with OCT and even newer versions of OCT that give us more detail within the retina and tell us which eyes are probably more appropriate than others. And there have been studies, I'm not going to go into it today, but have shown that certain types of thickening respond better to laser photocoagulation and others probably respond to some of the anti-VEGF drugs. The standard treatment using the ETRS, and this was from one of the publications. These images were taken immediately post laser photocoagulation on the left, and you can see there some considerable white burns, which are probably heavier than most of you treat. And you do get a fair resolution a number of months later. The cost of that being some increased scar tissue and the questionable improvement in vision or stabilization in vision. The ETRS study did show a reduction in visual loss, and for that our patients are grateful. But most of them nowadays expect a higher standard. They want to know, when am I going to see better, doctor? And that's a big problem, because oftentimes their systemic issues are difficult to manage, and we are essentially putting a Band-Aid on a big leak in a dike. So when we look at laser photocoagulation overall, we know that the benefits are reduction in terms of the thickening and some slight visual improvement. The problem is the thermal injury we still haven't really come to grips with. The induction of scotoma, which is sizable in terms of these patients being able to read, which most of them severely miss. And as I say, the majority don't experience any appreciable visual acuity improvement. Of recent years, we've had many forays into pharmaceutical solutions, and everybody got very excited with the introduction of intravitreal triamcinolone, and also of recent the use of Lucentis and Avastin and a number of others that are coming up. The only one that really has been tested in a large multi-center trial is the triamcinolone, and you're probably familiar with the publications that have come out showing 2-year, and I think there's one for 3 years, that have actually shown that laser photocoagulation is still better for our patients. Just to share the graphs that come from this particular study, it shows that over a period of time, while initially there was improvement with the intravitreal triamcinolone, over the long term, we see that laser actually turned out to be better in this large group of patients in terms of maintaining and perhaps improving visual acuity just slightly. Similarly, the reduction in thickness was better with photocoagulation. So the answer is laser is still our gold standard. And in terms of overall management, I think it will remain so for some time to come. Now the question remains, how do we improve this and optimize this therapy to enhance the visual results and the anatomic results and minimize the amount of injury? So looking at the parameters which appear to be critical, one is how well we actually target the pathology. So how well we can manage the patient sitting at the slit lamp and be able to see. And it always looks easier when you look at the images on your fluorescein viewer than when you look at the patient at the slit lamp. They're uncomfortable, they're moving, they're scared. There's a lot of really minimal movements cause a great deal of difficulty in terms of our visibility. So the precision of delivery is a critical issue, and you know, patients like to breathe. Some of them don't have perfect bodies, so some of them, when they fit in the slit lamp, when they breathe, you get a little seasick watching it. And of course, you have to breathe during the procedure, which is, you know, it's a limitation. So it tends to make the whole operation less than pleasant. There's also the problem that, you know, you either treat a little too much or a little too little, and you're not always sure at the time when you're administering it. And part of that is because the treating to the endpoint and trying to decide, have you hit the target that you want, and have you applied enough energy, you know, so that 3 or 4 months later, when you plan to evaluate what you've done, do you see an improvement, or is the patient gradually getting worse because you haven't, you know, sort of missed it at this particular juncture? When Iris came out with the yellow laser, it immediately had some very interesting options that I have to say that, you know, I've been using the infrared since I was a fellow, because it came out when I was a fellow, and I was involved in the initial studies and development of the transscleral retinal probe. And so we still use the 810, and those things don't die. It makes it hard to maintain a company when your products are so good that nobody wants to buy the next version. The 532, however, has a lot of advantages because the green is what we're used to, the standard from the original diabetic retinopathy studies in terms of doing, for our glaucoma colleagues, it makes it easier to cut iridotomies. So the endpoint tends to be a little bit better for treating the macula in terms of a conventional sense. The yellow wavelength, which has been around actually for a long time, it was originally available in the dye laser, which was had a large coherent dye laser, and it was very popular because the yellow matched the wavelength of the hemoglobin, which is something that this particular unit does, and it also it's very similar to the way that the green behaves, but it has some additional advantages. So one is that the visibility appears to be better with the yellow when you're actually at the slit lamp, and because it's a slightly longer wavelength, there seems to be less scattering. It's hard to tell when you're at higher powers because basically things tend to level out, but when you're trying to go for a minimal approach, in terms of panretinal photocoagulation, the yellow potentially has less pain because you use less energy. And the nice thing is, because it's yellow, it's not absorbed by the xanthophyll, which was a problem with the original DRS when we were using a green-blue argon laser. The other feature is that the particular wavelength tends to favor the oxyhemoglobin as opposed to the melanin, so probably causes less damage to the outer retina and focuses more on the inner vascular structures. So one of the features that I've liked and noticed early on, and I say that we haven't done an in-depth study because we've only had the laser intermittently for short periods, is that the burns definitely appear earlier and they appear easier to see. And talking to my friend Giorgio over here, trying to understand the physics of this, he was able to enlighten me on this. Basically, what we're looking at with the yellow is we can see the early burn in the RPE as opposed to the late movement of heat that's transferred to the inner retina. The being able to distinguish that early burn is critical, and with the blue-green there was some difficulty because of the scatter of the laser back to the operator's eye. Part of it is because the filtration of the 532 and other blue-green lasers are such that it tends to block the appearance until late, and so you're only seeing the appearance of the whitening of the retina, and you're not able to see the deep burn. And the deep burn is the one that you'd like to stop at, which would be preferential so that it would cause a minimal damage to the overlying retina. So you really, with the green and the blue-green, you need to go to a higher intensity before you actually see it. So the earlier blanching occurs at a lower temperature, as less scattering. The other feature that they've incorporated into this laser is at the moment that the laser is fired, is the red aiming beam turns off. And this is something a feature that was originally developed when we were first doing the transscleral retina probe, so that you could distinguish the burn at the earliest point. And that makes a big difference because, when you're staring, your eye tends to fatigue looking at the bright laser, even if you turn down your aiming beam as much as possible. As a surgeon, you're looking in there, and your retinas are subject to that intensity as well. So having that turn off, you're able to distinguish that early development. So that's, I think, a big plus. As I mentioned before, there's a reduced scatter, and the yellow is somewhat longer than the green, and because it's a logarithmic function, it does allow you to do a tighter burn because there's less spread. The absorption in the level, you can see that the 577 actually meets this peak at the peak of the absorption of the oxyhemoglobin, which basically improves the ratio of you can see the melanin up above in brown, and you can see that you have the best overall ratio between absorption of the hemoglobin and the melanin. So you're going to have less damage to the outer retina, which doesn't really help you for the most part. Although the stimulation of the RPE is probably important in terms of some reabsorption of the fluid. Now, the thing that I particularly like about the laser, and that I found particularly useful for the residents, is the fact that the filtration system of the 577 allows you to use a red-free filter. Now, with a red-free filter, it really accentuates the visibility of the xanthophyll pigment. So you see the macular pigment, the spot, and a lot of times you can't tell when you're looking at a patient exactly where the fovea and the parafoveal region begins. So if you're trying to treat, as in this particular case, very close in to the FAZ, and you want to treat the microaneurysms that are close, because if you look at the OCT here, the two humps of the parafoveal region now are kissing each other, and you can't really see the fovea in this OCT. The two of them are like this as opposed to like this. So it's very difficult to understand the anatomy when you look in. And you can see from the fluorescein what you should be treating, but you can't necessarily distinguish it when you're looking clinically. Especially when you're looking at a fundus image, which you don't see the microaneurysms all that well, and you see a confluence of red, and the fovea tends to be a little bit dark anyway. So trying to decide how close you can treat is a big problem. Now, if you shy away and you say, well, I don't want to do any damage, that's fine. But, your result probably is not going to help the patient. They're going to see the same. And I've been going through this for years. And it's very disturbing, to tell them, well, you have to wait a little bit longer, and you do this song and dance, and you go through the whole reason. But the issue is you were just a little bit shy of being able to treat as close as you potentially could. But if you use the red-free, you can see how well it distinguishes the macular pigment, and it shows you the microaneurysms. Now, you might decide you don't want to treat in green because it's a little bit disorienting, so you can go back and forth. You can't do that with the 532 because the filter that's there to protect your eyes is fixed. And so if you add the green filter in on top of that, it looks like mud. So you really can't see anything. You can't get the light bright enough without the patient, standing up and leaving. I always like to test these ideas with my residents because they don't have any intellectual baggage from years of doing these things. So, we do, in my retina clinic, the second-year resident does the laser. So I said, well, let's try this, and you'll see, I'm going to let you treat these areas, but you have to, you use the green and see what it does. And 2 residents so far who've been on the rotation have both said, this makes me a lot more confident that I know when I'm close to the fovea, because once you have the macular edema, you don't have the landmarks. So I think that in itself is a big plus in terms of your comfort compared to using the 532. So this is just a blow up of the same one. And I think that one safety feature, it may seem small, but it's sizable in terms of your practice. Here's an example of one patient. Now, one patient doesn't really mean anything except that this particular patient was treated when they brought the laser in early on, earlier in the year, about just before ARVO time, and we tried it out. And I treated this particular gentleman. He was one of these patients that's very difficult. His vision was he came in, his vision was about 20/80. He's a relatively young man who's still actively working and trying to drive, and he was unable to, see well enough to drive at this point. And you can see he's got that same configuration where the 2 humps of the macula are pretty much butting heads. And I only treated him once. He had a triamcinolone treatment, didn't really do anything. But after about 4 months, about 5 months, he came back, and I was amazed, because I treated very close in. And pretty much the central area, you could see his fovea again. So, as I say, this is only one example, but the concept of being able to treat close is very useful. Now, there's been a lot of work, and you're going to hear from people who've done much more of this than myself in terms of subthreshold therapy. And the subthreshold treatment using the micropulsing, I think, has a lot of potential. We tried it initially with the 810, and a lot of people embraced it and thought that they liked it. The feedback using an infrared laser in the macula always been a little bit uncomfortable. I like the ability to use either visible endpoints or non-visible endpoints, but the concept of micropulsing is basically reducing the heat spread, which is unwanted damage that you really don't need. And I think that it has a lot of potential, and you're going to hear more after me, people who embrace the technology to a much greater extent. But basically, by chopping the pulse, you just don't get the heat spread. And until recently, I say it was only available in the 810. The 532 didn't have this capability. So, most people don't use the 810 in their office. I think they may still use it in surgery. We don't have that capability in the office, so we haven't really been able to. But with the 577, you now have the option to use that as well as the regular continuous visible wavelength. And the idea here is that, again, it's similar to looking at the early burn, except you're just really stimulating the RPE, and you're not allowing the damage to proceed to that white end. I think that the concept of doing just laser therapy to the RPE is a very interesting and concept and has a lot of potential. The physics makes a lot of sense. Sometimes the translation of the clinical science is somewhat difficult for us to embrace. We tend to be conservative as surgeons because we have a lot riding on everything we do, and we want it to be proven multiple times before we get comfortable with a new concept. And we've been comfortable with early treatment with very low dose laser, but not the no visibility types of lesions. At least I haven't been. And I think that I'd say that's probably the majority of people. But that being said, there are individuals who have embraced this, and you'll hear more about this later. But I think it is very interesting and has a lot of potential. And the concept is, if you treat with these very short pulses, that you're not transmitting this energy. You see how the curve just flattens or goes down as you get to very shorter pulses. It doesn't allow the heat to spread into the retina. It stays confined to the RPE. And I think that that's going to be a very important modality as we move ahead. The problem has been trying to image this and appreciate it in a way that we can reassure ourselves that we're doing the best for the patient. And you can see the picture on the left is looking at the very short micropulsing as opposed to the continuous wave. And there's even a shorter treatment with selective retinal treatments, but those tend to produce small bubbles and you get little pops which potentially may cause some retinal damage. So that's an even more in the future treatment, potentially, even shorter waves. But I think that this does hold a lot of potential. So there have been a lot of studies. You can look at them. They've been going on now for well over 10 years and using the short micropulsing. And it may turn out that this is going to be a better modality. I think that time will tell whether the 577, I think more people will be able to embrace it and use it in their clinical practice. It does seem to show therapeutic benefits. Whether it's comparable to what we're used to in terms of visible endpoint photocoagulation, it will require some large studies. So just to sum up, the 577 really gives us a lot more ability to use. We can use the continuous wavelength. We can use focal treatment for microaneurysms. You can do the conventional PRP, and you can use short pulses similar to what's been championed in the Pascal system, or you can use a subthreshold. So there's a lot of options that this particular laser has that we didn't have in some of the older models. And using subthreshold may turn out to be the answer. It's always the question, is this the emperor's new clothes? And I think that's what is still disturbing for a lot of people. So in summary, I think it allows lighter treatments, better visibility, and hopefully better outcomes for our patients. And I'll be happy to answer any questions. Thank you.